Attention all employees. That voice booms over the warehouse PA system at Booker Manufacturing. Everything just stops. Will all third shift MERT members please respond to the number 7 loading dock for a medical emergency? And just like that, Joannie and Renee, 2 MERT members, grab their gear. You can almost feel the tension, right? They head to the docks. Joannie says, I'll be the patient care person if you'll do scene control. Renee's newer, so Joannie's taking lead. They get there, and Tariq, a forklift operator, he looks terrified. He just blurts out, I'm glad you're here. It's one of the truck drivers. I think he's having a heart attack. Wow. Imagine walking into that, the urgency, the fear in the air. But what's amazing is how people like Joannie and Renee bring order to that chaos. There's a method, and that's what we're diving into today. Patient assessment. It's the absolute bedrock skill for any emergency responder, even for a bystander, really. It's about quickly and methodically figuring out what's wrong.
Exactly. And that systematic approach, it's the foundation for everything else you do. It isn't about nailing a final diagnosis on the spot that often comes later.
Yeah.
It's about spotting illness or injury fast and deciding on the right immediate care. Now, you asked why the method, why be so structured? Well, in those moments, your brain's overloaded, adrenaline's pumping. A clear process, it stops you from missing something vital. It's your roadmap in the fog, basically. If you rush it, if you're disorganized, you're almost guaranteed to give less effective care. It's that simple.
Okay, so our mission for this deep dive is to break down these key principles. We want to give you that roadmap, show you how pros think in emergencies, and honestly, give you some powerful tools for just observing critically. For those of you actually in emergency response, a lot of this will sound familiar, but maybe we can shed light on some nuances. And for everyone else, you'll get a real appreciation for the structured thinking that saves lives. So back to Joannie and Renee. Before they even got close to Brad, the truck driver, before any hands-on assessment, there's that critical first step. The scene size up. As they walked up, they were already scanning everything. What does that involve?
It's job number 1. Before you even think patient, think of it like being a detective. You're looking for clues about danger and clues about what actually happened. First up, BSI precautions, body substance isolation. That means at the very least gloves on, maybe eye protection if you have it.
Why is that so immediate?
Because you never know what you're walking into. Fluids, maybe, it protects you. And importantly, it protects the patient from anything you might be carrying. It's mutual. You skip it, you actually add risk. Then, even more critical, scene safety. This is absolutely non-negotiable. You cannot help anyone if you get hurt yourself. So you're looking fast. Obvious dangers. Broken glass, maybe down power lines, fire, traffic, less obvious stuff, hazardous materials, even an angry dog. If that scene isn't safe, you just don't go in, period. It takes discipline sometimes to hold back when someone needs help, but it's the right call.
Yeah, that instinct to rush in must be strong, but I see how it could backfire badly if you're not careful. Okay, scene safe. What's next for figuring out the story of what happened?
Right. Next is understanding the mechanism of injury, MOI, or the nature of illness, NOI. MOI is about the force that caused an injury. Trauma stuff, like a bent steering wheel, makes you think chest injury, cracked windshield, head injury possibility, a fall from a certain height. You're immediately thinking of potential spine injury. It's like piecing together the physics of the event to guess what might be damaged, even if you can't see it yet.
Okay, so that's the how of an injury. What about NOI?
NOI is for medical calls. It's what's medically wrong. So chest pain, difficulty breathing, maybe bad abdominal pain, that kind of thing. Knowing the MOI or NOI helps you anticipate complications. It gets your brain ready for what might be coming, even hidden problems. And while you're doing this initial scan, you're also figuring out the number of patients, just one or more. And do you need DSHNs, additional resources? Call for that ambulance or fire department or police early if you think you'll need them. Don't wait. And for trauma, right from the start, you're considering spinal precautions. Protecting that spine is always high on the list if the MOI suggests it.
It's amazing how much you can gather just by looking around before you even talk to someone. Okay, scene's safe. You've got some clues about what happened. Now you approach the patient. Joannie introduced herself, asked Brad for permission. Consent seems important.
It is. You need consent. Either express consent, they're awake, they say, yes, help me, or implied consent, they're unconscious, maybe confused. The law generally assumes they'd want help. Once consent is clear, you start the primary assessment. The whole point here, find and fix immediate life threats. Airway, breathing, circulation, major bleeding, the ABCs. You deal with them as you find them. It kicks off with your general impression. This is that first, almost subconscious sizing up of the patient.
Like a gut feeling.
Yeah, partly. Don't dismiss your gut feeling. It's often your brain recognizing patterns super fast based on, experience or just knowing something's off. But it's also conscious observation, approximate age, sex. How much distress are they in? Are they clutching their chest, gasping? This gives you a quick sense of severity, helps decide how urgent transport might be. Then you check their mental status. We use the AVPU scale. It's quick. Alert. Are they awake? Do they know who they are, where they are, what time it is? Talking normally? Verbal? Okay, not alert. If you talk loudly, do they respond? Maybe a groan or their eyes flutter. Painful. Still no response to voice? Try a painful stimulus. A gentle rub on the sternum, maybe a pinch on the arm. Do they react only to that? Unresponsive. Nothing. No response to anything.
That seems pretty straightforward.
Mostly, yeah. But say with older folks, dementia can really complicate judging their alertness, right? You might need family there to tell you, no, this isn't his normal. That baseline is key. Next, A and B, airway and breathing. Simple questions. Is their airway open and clear? Can air get in and out? Are they actually breathing adequately? And watch out for gasping, sometimes called agonal breathing. It looks like they're trying to breathe, but it's not effective. That's a huge red flag, not normal breathing at all.
Okay. Airway clear. Breathing seems okay. Let's see.
Circulation. First, find a pulse. In adults, the carotid artery in the neck is usually easiest to find and most reliable, especially if they might be in shock and their peripheral pulses are weak.
Not the wrist.
You can try the radial pulse at the wrist, but carotid is often better in emergencies. For infants, it's the brachial pulse inside the upper arm. Check for about 5, maybe 10 seconds. Feel for rate and quality. And really important, never check both carotid arteries at the same time.
Why not?
You could actually reduce blood flow to the brain doing that, so one side at a time. And with older patients, their pulse might be irregular. That's pretty common. The rate, how fast or slow, is usually more important than perfect regularity. Circulation also means checking for serious bleeding. Are they losing a lot of blood? Bright red, spurting blood. That's likely arterial, very dangerous. Darker red, steady flow, probably venous. The key insight isn't just the type of bleeding, but the volume. How much have they lost? Even slower bleeds add up. If you see serious bleeding, control it immediately. Direct pressure usually works.
But you said ABCs.
Right. Control the bleeding, absolutely. But don't get so focused on it that you forget about airway and breathing. Those always take priority. If they can't breathe, stopping the bleeding won't matter much.
Wow. Okay, that primary assessment. It sounds like a whirlwind of critical checks in just moments. You're finding and fixing life threats right there. Let's say you've done that. Joanna got Brad breathing, okay, he's talking, pulse is there, no massive bleeding. What's next? Clearly, there's more going on if you might be having a heart attack. How do you dig deeper?
Exactly right. Once those immediate life threats are managed, you move to the secondary assessment. This is where you do a more detailed, systematic check to find other injuries or get more info about their medical problem. And how you do it really depends. Is it a trauma patient, someone injured by a force? Or a medical patient, someone who's sick?
Let's start with trauma. Say, a car crash victim.
Okay, for trauma, the big question is, was there a significant mechanism of injury, a significant MOI?
What counts as significant?
Things like being thrown from a car, ejection, a fall more than, say, 15 feet for an adult, a high-speed crash, rollover, maybe being hit by a car, unresponsive after trauma, penetrating wounds to the head, neck, chest, abdomen. For kids, falls over 10 feet, or being hit by a car or bike at moderate speed. Basically, force is strong enough that you suspect serious internal injuries even if you don't see them yet. If there's a significant MOI, you do a rapid secondary assessment. Head-to-toe check. Fast. Aim for about 90 seconds.
90 seconds, head to toe. How?
Practice and mnemonics help. We use things like BPDOC or DCAP-BTLS to remember what to look and feel for.
BPDOC.
Bleeding, pain, deformities, open wounds, crepitus. Crepitus is that gritty feeling or sound of broken bone ends rubbing together. Finding that tells you a lot. Or DPK-BTLS. Deformities, contusions, bruises, abrasions, scrapes, punctures, penetrations, burns, tenderness, pain on touch, lacerations, cuts, swelling. It's a mental checklist as you quickly run your hands over them. Look closely. Head, bleeding lumps, check pupils, any fluid from ears, nose. Neck, pain, deformity, or the neck veins bulging, JVD. Trachea, midline. Chest, pain, deformity, does it rise and fall equally? Any paradoxical movement where a section moves opposite to the rest, that suggests a flail chest, very serious. Abdomen, dot pain, is it rigid or soft, distended, pelvis. Gently press inwards, check for stability, pain, extremities. Pain, deformity, can they feel you touch them? Sensation, can they move? Motor function and rate. Check circulation down low. You're looking for anything out of place, and always be respectful, maintain modesty.
Okay, that's if the MOI was significant. What if it wasn't? Like someone just tripped and twisted their ankle.
Right, no significant MOI. Then you do a focused secondary assessment. You just concentrate on the injured area, the ankle in your example. A more detailed check of just that part.
Makes sense. Now, what about a medical patient, like Brad, with the possible heart attack?
For medical patients, it depends on responsiveness. If they're unresponsive, you actually do a rapid secondary assessment similar to the significant MOI trauma patient, but you're looking more for signs of illness.
Like what?
Things like, again, neck vein distension, JVD, listening to breath sounds, feeling the abdomen, checking for incontinence, looking for medical ID tags or bracelets, stuff that points to a medical cause. If the medical patient is responsive, like Brad was initially, you do a focused secondary assessment based on their chief complaint. What are they telling you is wrong? Chest pain. Okay, let's focus on assessing their chest, breathing, circulation related to that.
It sounds incredibly systematic, which makes sense given the pressure. But how do you get the patient's side of the story, especially if they're responsive? Their own words must be gold.
Absolutely crucial. That's where gathering a sample history comes in. It's another mnemonic. Makes it easy to remember what info you need.
Okay, hit me with it. Sample. Signs and symptoms. Signs are things you can see, like sweating or pale skin. Symptoms are things they feel, like nausea or pain. Ask, what are you feeling right now?
Allergies. Super important. Are they allergic to any medications? Foods? Latex. You need to know before anyone gives them anything. Medications. What are they taking? Prescription meds. Over-the-counter stuff. Vitamins, supplements. Get specific names if possible. And yeah, we usually say medications, not drugs. Just sounds more professional and less loaded. Pertinent past medical history. Any history relevant to this. Previous heart attacks. Diabetes. Seizures. Last oral intake. When was the last time they ate or drank anything? This matters if they might need surgery later. Events leading up to illness or injury. What was going on right before this started? What happened?
And how you ask is important too. Make eye contact. Speak calmly, clearly. Don't ask leading questions like, your chest pain isn't that bad, is it?
Right. You don't want to influence their answers. Exactly. And avoid false reassurance. Don't say you'll be fine. Be honest but supportive. We're doing everything we can to help you. And absolutely write down their words. If they say it feels like an elephant is sitting on my chest, that's powerful info. You use those exact words.
Is there a way to dig deeper into specific symptoms like pain?
Yes. For pain or shortness of breath, we often use OPQ-RST. Another mnemonic. Onset. When did it start? Suddenly. Gradually. What were you doing? Provocation, palliation. Does anything make it better or worse? Movement, rest, position, quality. What does it feel like? Describe the pain. Sharp, dull, crushing, burning, tearing, region radiation. Where exactly is it? Does the pain stay there or does it travel anywhere else? Like down the arm or up to the jaw, severity. On a scale of 1 to 10, with 10 being the worst pain imaginable, how bad is it right now? Time. How long has it been going on? Is it constant or does it come and go?
OPQRST. Okay, that gives a really detailed picture of the pain itself.
It really does. And just a quick note on getting history from older patients. Remember, dementia can make it tough. Hearing loss is common, so speak clearly. They might have a higher pain tolerance, so just because they aren't screaming doesn't mean it's not serious. A thorough assessment is vital. Asking to actually see their pill bottles can be incredibly helpful too.
And if they're unresponsive?
Then you're relying on family, friends, bystanders. Ask them, what happened? Did they witness it? Does the patient have any known medical conditions? Take any meds? And always look for medical alert tags, necklaces, bracelets, wallet cards.
Okay, we've covered the standard assessment sequence pretty thoroughly. But you mentioned earlier things change with different age groups. What are the key differences when assessing kids or the elderly? They're not just small or old adults, right?
That's a really critical point. They absolutely aren't. Let's take infants and children. Physiologically, they're just different. They might be scared or shy with strangers, but an unresponsive child who isn't crying or reacting to you. That's usually a very bad sign, much more ominous than in an adult sometimes. Their airways are smaller, floppier. How you position them to open the airway is different. More of a neutral position for an infant, maybe just slight extension for a child, not tilting the head way back like an adult. Their breathing rates, their pulse rates naturally much faster. You need to know what's normal for their age. Circulation check. Brachial pulse, yes, but capillary refill is often a much better indicator of shock in kids than blood pressure.
Capillary refill.
Yeah, how does that work? You press gently on their fingernail bed or maybe the palm or sole of their foot until it blanches white. Then you release and count how long it takes for the normal pink color to return. It should be quick, less than 2 seconds.
And why is that more reliable than BP sometimes?
Because kids have amazing compensatory mechanisms. They can lose a significant amount of blood volume and still maintain a decent blood pressure right up until they suddenly can't anymore. They fall off a cliff, clinically speaking. That delayed capillary refill. That's your early warning sign that things are going south, even if the blood pressure still looks okay-ish.
Wow, okay. So that's kids. What about geriatric patients?
Older adults bring their own set of challenges. Because of potentially brittle bones or other conditions, they can suffer much more severe injuries from what seems like a minor fall or impact. A lower MOI can cause bigger problems. We mentioned irregular pulses are common focus on the rate. Dementia can make assessing mental status or getting a history very difficult. Rely on family or caregivers for that crucial baseline information. They often have a higher pain tolerance or may describe pain differently. So again, a thorough physical exam is key because they might not tell you about something that really hurts. You have to find it. Assessing breathing can be tougher too. Their chest wall might be more rigid due to arthritis or other changes, so you might not see as much chest rise. Watching their abdomen for effort can sometimes give you a better clue. And just respect. Address them formally, Mr. Smith, Mrs. Jones. Avoid terms like dear or gramps. It builds trust, which is essential for a good assessment.
That makes a lot of sense. Respect goes a long way. Okay, so we've done the scene size up, the primary assessment, the secondary assessment, considered special populations.
Yeah.
It feels like we have a good picture. But you said it's ongoing. It's not just assess once and done.
Absolutely not. The patient's condition can change, sometimes very quickly. That's why reassessment is a continuous loop. You're constantly monitoring. You repeat parts of the primary assessment, check their mental status again. Are their ABCs still good? You reassess their vital signs.
What are the core vital signs you're tracking?
Pulse rate and quality, respiratory rate and quality, skin signs like temperature, color, condition. Is it warm and dry, cool and clammy, pale, flushed?
Yeah.
Pupils, are they equal, reactive to light, and often blood pressure. If you have the equipment in training, the first set you get, that's the baseline vital signs. Every set after that, you compare back to the baseline and previous readings. That's called trending.
Trending. This is like seeing if they're getting better or worse over time.
Yeah. Exactly. Is the pulse getting faster and weaker? Is the breathing getting shallower? Is the skin becoming cool and clammy? Those trends tell you a huge amount about whether the patient is improving, staying the same, or deteriorating. A single set of vitals is a snapshot. The trend is the movie.
How often do you reassess?
Depends on the patient. If they're unstable, seriously ill, or injured, every 5 minutes. If they seem stable, maybe every 15 minutes. But honestly, for critical patients, by the time you finish one reassessment cycle, it's pretty much time to start again. You also reassess any interventions you've performed. If you put on oxygen, is it helping? Does the bandage need adjusting? Do they need to be repositioned? And finally, all this information culminates in the handoff report when more advanced help arrives, like the ambulance crew Joannie and Renee handed off to.
Right, making it seamless.
Yeah, you give a concise, clear report. Who the patient is, name, age, their main problem, chief complaint, their mental status, the state of their ABCs, key findings from your assessment, sample history highlights, what you did, interventions, and how they responded. It's that vital bridge to ensure nothing gets missed as care transfers.
From that chaotic scene at Loading Dock 7 to a smooth handoff, it really highlights the power of that systematic approach. So as we wrap up this deep dive, what's the big takeaway? What does all this mean beyond the immediate emergency?
Well, the core takeaway is that patient assessment isn't magic. It's a skill built on systematic observation, methodical steps, and critical thinking. And it's all guided by that fundamental principle. First, do no further harm. But thinking bigger. This raises an interesting question, doesn't it? How can applying this kind of assessment mindset, the deliberate observation, gathering information systematically, looking for changes and trends, evaluating critically, how can that help you navigate complex situations or information overload in your own life? Whether it's a problem at work, understanding a news story, or even a personal challenge. Being more methodical, less reactive, allows you to be more informed, more effective, really, in almost any scenario you face. It's about seeing clearly before acting.